Good morning, all. Today's our topic is drug acting on the peripheral nervous system and the skeletal muscle relaxation. Skeletal muscle relaxation are drugs that act peripherally at neuromuscular junction, muscle fiber itself, or centrally in the cerebrospinal axis to reduce muscle tone and or causes paralysis. The neuromuscular blocking agent are used primarily in conjunctions with the general anesthetic to provide muscle relaxation for surgery, while centrally acting muscle relaxants are used mainly for painful muscle spasm and spastic neurological condition. Now, peripherally acting muscle relaxation. Neuromuscular blocking agent, non-depolarizing blockers. They are long acting, they are intermediate acting and short acting. In long acting, tubuculin and pancreonium, and intermediate acting, vecuronium and acro, atracurium, and short term, mivacurium. Depolarized blocking blockers, succinylcholine and uh, decamethonium. Directly acting agent, dendrolan sodium and quinine. Neuromuscular blocking agent, curare. It is the genetic name for certain plant extract, extracts used by South American tribals as arrow and poison for uh, game hunting, and the animal got paralyzed even if not killed by the arrow. And natural source of the cure are strychnos toxifens and tubuculin was first clinically used in the 1930 and mainly synthesized compounds including succinylcholine were introduced subsequent. Such has continued for the neuromuscular blockers. Mechanism of action. The site of the action of both competitive and depolarizing blockers. It is end plate of skeletal muscular fiber. Now, competitive blocks. This is produced by um, Curare and related drugs. Claudel Bernard, Bernard 1856 precisely localized the site of the action of the curare to be the neuromuscular junction. He stimulated the static nerve of uh, pathed frog and recorded the contractions of the gastrocnemius muscle. And injection of curare is the ventral limb sacs causes inhibition of the muscle twitch, which there was no effect of the blood supply of the hind limb was occulted. The comparative blockers have affinity for the nicotinic cholinergic receptors at the muscle and plate, but have no intrinsic activity. The N small m NM receptors has been isolated and studied to detail. Here the chemical structures of the three neuromuscular blockers, D-tubuculin and decamethonium and succinyl choline. The competitive blockers also blocks projectional nicotinic receptors and located on motor nerve endings. Since Activation of these receptors by acetylcholine normally facilitates mobilization of additional quanta of acetylcholine from the axon to the motor nerve endings. Uh, Titanic stimulations during partial non-depolarizing block increasing the response to a subsequent signal stimulations, which is called post-tetanic poten- potentiation and is probably due to a transient increase in the uh, prejunctional acetylcholine mobilization. Depolarizing block, uh, decamethonium and SCH have infinity as well as submaximal intrinsic activity at the NM cholinereceptors, and they depolarize muscles and plates by opening sodium channels and initially produce twitching of fasciculation because in the focally innervated mammalian muscles and stimulation is transient, longer lasting, and depolarization of muscle and plate produces receptive excitation of the fiber. Depolarizing blockers also have two quaternary sodium atoms, but the molecule is long, slender, and flexible terms leptocurare by Bevet. The features of the classical depolarizing block differs markedly from that of non-depolarizing block. Phase 1 block, it is the rapid in onset and results from persistent depolarization of muscle and plate and has features of classical depolarization block, and this depolarization declines shortly afterwards and depolarizations occur gradually despite. Now this is the figure of illustration of the characteristic of competitive. A depolarizing and B is neuromuscular blockers. Now phase 2 blocks. It is slow in onset and results from the desensitization of the receptor of acetylcholine. It therefore superficial resemble block produced by DTC, and that muscles membrane is nearly repolarized. Recovery is slow and contraction is not sustained during tetanic stimulation. In men and fast contracting muscle of cat, normally only phase 1 block is seen, and phase 2 blocks may be seen in men when SCH is injected in high dose of infuse. Now this is the table of features of competitive and typical depolarizing block. You can read the all kind of muscles in where it is the competitive block and depolarizing block. Actions: skeletal muscles, innervations, injection of the non-depolarizing blockers rapidly produce muscle weakness followed by flaccid paralysis. Small fast response muscles are affected first. Paralysis spread to hands, feet, arm and leg and neck, face and intercostal muscles, finally diaphragm and respiratory stop in the rare of the attainment of the Park effect. Depolarizing blockers typically produce fasciculations lasting a few seconds before inducing flaccid paralysis. But fasciculations are not promoting in well anesthetized patient. Now, here the figure of the clinical assembles of the neuromuscular block, 10 of the 4, and B, the double burst stimulation. Now autonomic ganglia, because the cholinergic receptors is autonomic ganglia are nicotinic competitive neuromuscular blockers produce some degree of ganglionic block. Histamine release. DTC release histamine from mast cell, and this does not involve immune system and is due to the bulky uh, cationic nature of the molecular histamine release. Next, CVS. D-tuberculin uh, produce significant falls in the BP, and this is due to the ganglionic blocked histaminic release and reduced venous return, a result of paralysis of limb and respiratory muscles. This is the table of the comparative properties of the neuromuscular blocking drugs. It is a long-acting, intermediate-acting, and short-acting, and its doses, onset, duration, systemic release, ganglionic block, and a vagal block. GIT have ganglionic block activity of the competitive blockers may enhance uh, positive paralysis, and CNS all numerous blockers and the content compounds. And here the pharmacological actions, neuromuscular blockers are poor for quaternary compounds and not absorbed orally, so not cross cell membranes and have low volume of the distribution and do not penetrate placental or blood-brain barrier. Non, here the knots of involving compounds. The D-tuberculin, because of its prominent histaminic releasing ganglion. Succinylcholine deposit its propensity to the causes muscle fasciculations and the soreness, changes in the BP and HR, and arrhythmias, histamine release, and potassium influx from the muscle causing hyperkalemia and its compositions. Now, pancuranium is synthesized steroidal compound 5 times more potent and longer acting than DTC, provides good cardiovascular stability and seldom induce flushing bronchospasm or cardiac arrhythmias. Doxycycline, a bisequentially muscle relaxant. Papillocurium, another muscle relaxant, and vacuum, a closed generation of the pancuranium with the shorter duration of reaction due to the rapid distribution of the metabolism. And antracurium, a bisequential competitive blockers and 4 times less potent to the pancuranium and the shorter acting. And another drug is cistacaricium, and they recommend ricoronium. Now, interaction. Theopenic source, general anesthetic effect, and anticholinergic esters, antibiotics, calcium channel blockers, and diuretics. Now, toxicity, respiratory paralysis, fall of the blood pressure, cardiac arrhythmias, and precipitation asthma, perforated muscles, and malignant hyperthermia. Which is the most important use of the neuromuscular blocker. It is adjacent to the general anesthesia.